Coming to pathophysiology, the possible theories are a defective bicarbonate secretion leading to increase in the protein in the secretions, leading to plug formations within the acini and the ducts, which leads to obstruction. Possible intraductal activation of digestive enzymes leading to inflammation and fibrosis. Intraglandular release of inflammatory cytokines leads to swelling and increase in the intracapsular pressure leading to pain. Now coming to presentations, they can present only with pseudocyst formation. The pseudocyst can be single or multiple, or it can be small or large. They are lined by granulation tissue and fibrosis and contains digestive enzymes. They do not have necrotic material. Pseudocyst may present with abdominal pain, duodenal obstruction, biliary obstruction, vascular occlusions, fistula formation to adjacent viscera, pleura, or even pericardium. It can present with infection and abscess formation or a sudden painful expansion due to bleeding. Coming to clinical examination, there is no clinical sign to help the diagnosis of chronic pancreatitis. Signs of malnutrition may be present if the presentation is late in the stage, showing a decreased subcutaneous fat, temporal wasting, sunken supraclavicular region. These are all seen only in the late stages of the disease. Coming to investigation, serum amylase and lipase, which are the markers of acute pancreatitis, are not useful in chronic pancreatitis. Serum trypsin level are low, but it is not sensitive enough. Fecal fat estimation for 3 days with more than 7 grams per day is confirmatory of chronic pancreatitis, leading to exocrine functional deficiency. But it is not useful until very late stage of the disease. Fecal chymotrypsin and human pancreatic elastase 1 are more specific than fat, but useful only in advanced diseases. Coming to the investigation, abdominal X-ray will show pancreatic calcification, very classically pathognomonic of chronic pancreatitis. Obviously, AP and oblique view should be done for the abdominal X-ray to see the calcification in front of the vertebra and across the vertebra at the level of L2. Calcification could be in the duct or parenchyma, common in alcoholic, tropical and hereditary pancreatitis. Next imaging is CT. CT is useful in study of the pancreatic morphology. It definitely excludes other causes and other diseases and identifies the complications as well. MRI and MRCP are more superior, and secreting stimulated MRCP is more accurate. ERCP clearly defines the ductal system but has no value in parenchymal assessment. Advanced fibrotic pancreatitis can have normal ductal system. Coming to the recent development of endoscopic ultrasound. The features of chronic pancreatitis in endoscopic ultrasound are presence of stone, cysts, lobularity of the pancreas, irregular pancreatic ducts, hyperechoic foci or strands, dilatation of the main duct, hyperechoic main duct margins. EUS has an advantage of doing an FNAC or true cut biopsy of the lesion.